We will have Dr. Kavitha, who heads the glaucoma services at Aravind Hospital, Pondicherry, talk to us on managing post-operative hypotony and also the post-operative raised pressures after glaucoma drainage device implantation.
Thank you, sir, and thank you, AIOC, for the opportunity. So basically, I'll be covering the intraocular pressure-related complications following a glaucoma drainage implant. To start with, we'll deal with the hypotony in GDD. So there are many definitions followed in many studies. Statistically, it is defined as an intraocular pressure less than 6.5 millimeters of mercury, that is more than 3 standard deviations below the mean intraocular pressure. In TVT study, it was the persistent hypotony was defined as an intraocular pressure of 5 millimeters of mercury or less at 2 consecutive follow-up visits, whereas in ABC study, it was defined as intraocular pressure less than or equal to 5 millimeters of mercury. So the hypotony following a glaucoma drainage device, especially following a non-valve glaucoma drainage device like RD, can happen in 3 different phases. The first is the early post-operative hypotony. The early post-operative period, the causes can be as shown here. It can be a peritubular leakage, and our chief instructor, Dr. George, was repeatedly stressing the importance of making the needle track, and while we come out, he said that it should self-seal. That is very, very important. And when we take care of this peritubal leakage, completely from this post-operative complications, that can be easily an avoidable one. So we have to make sure we make a proper scleral track so that the tube will snugly fit inside the track. The next cause in the immediate post-operative period can be inadequate tube ligation during the surgery. Just to avoid the same, we always go for 2 ligation sutures so that by chance if one becomes loose, the other will always be there to take care of the hypotony. The other can be because of the venting slits. It is not mandatory to make venting slits in all the patients, and wherever it is avoidable, it is better to avoid that. And also there are some tips in making the venting slits. So we can see here, this is the tube entry side and the venting slits are being made here. It is always good to make the venting slits little bit posterior, more towards the ligation suture, so that in case of this hypotony related to that of the venting slits, you have a anterior portion of the tube available where you can apply a religation suture. So that we have to keep in mind. So the next phase where we can expect hypotony following a non-valve glaucoma drainage device is when the ligation gets absorbed. It happens around 5 to 6 weeks time, and most often when the hypotony happens, there will be a severe anterior chamber inflammation also. When the chamber is formed only with inflammation, usually it resolves around 72 hours. And we can see here, and once the ligation opens, the anterior edge of the foot plate, episcleral plate, will get obscured and we'll get a good diffuse bleb to visualize. And the most dreaded complication is the vision threatening one is the unexplained late hypotony, which can be accompanied by choroidal effusions, choroidal hemorrhage, and hypotony maculopathy. So how to manage? As I said, in the immediate post-operative period, when it is related to the ligation absorption, initially we can observe the patient and start the patient on topical oral steroids or cycloplegics, as we always manage with hypotony. And here we can see a patient, a thick fibrinous membrane, almost a flat anterior chamber because of the hypotony following the RD. When we have such patients which is not resolving with medical management, we usually either can go for a tube religation, ab interno stenting using a supramid suture, and tube religation with or without a CD drainage depending upon the extent of the choroiditis. So usually when it is not resolving in 24 to 72 hours, it is better to intervene. So here so there's a small video demonstrating tube religation. We can see here how shallow is the anterior chamber, and there is a thick fibrinous membrane in the pupil. So after forming the chamber and giving subtenons, I am placing a traction suture, and careful dissection should be made in the area of the tube. And one more tip here in this patient is, you can see here, this is one of my few initial cases where I was regularly using the patch graft, and nowadays when we are entering 4 millimeter away from the limbus, and we have good evidence from our chief instructor to show that patch grafts are not mandatory in all the patients. And we can see here, though I have used patch graft, I have limited it to cover the anterior most part of the tube, and the posterior part is not covered. So in these patients, it is very helpful, especially when such hypotony happens, just to make a small conjunctival nick and religate the tubes. So that also like one of the tip which I wanted to share. Here I am using a cyclospatula to separate the tube from the surrounding fibrous tissue, and then using the same vicryl suture to ligate in the same fashion as we routinely do during the surgeries while implanting in the primary surgery. After religating the tube, the conjunctiva is carefully closed, and then we have to form the anterior chamber. We can see how thick fibrinous membrane has formed because of the hypotony related inflammation. So now it has become very much easy with the availability of Supramid suture. 30 Supramid suture is available from Lab. When the hypotony happens, like we have the option of stenting the tube, intraluminal stenting. I am making two side ports, one closer to the tube and one exactly away from the tube entry. Just creating a bevel as usually we create it for the tube, so that its entry into the tube becomes easy. So 5 to 6 mm of Supramid suture, 30 Supramid is being inserted into the tube. I am using a MVR forceps so that it can easily enter through the side port. And care should be taken to push the Supramid suture completely into the lumen of the tube, so that it should not be protruding into the anterior chamber. So this is a patient who presented with the hypotony, whose surgery like we saw just now. It's like a preoperative picture. We can see massive choroidals here, and we can see a stenting over here, and the chamber formed very well, and the hypotony completely resolved in the next 2 to 3 weeks time, as it is evidenced in this B scan pictures. So, and Dr. Neetu was also showing the importance of using ripcord, and Dr. Jat sir was just suggesting me to use the ripcord suture in almost all the patients. So we can place the ripcord suture and then ligate the tube before even inserting into the under the muscles and fixing the tube. And while ligating, we can make sure like to put 2 ligation sutures. One over the, sorry, the video is not playing. So one suture can be placed over that Supramid, and the other suture can be placed just anterior to the top of it, so that the issue of it not being fully like tight enough can be easily avoided. And we can just can close the, I'll go to the second slide. So this is the, it's moving on its own. Please stop, I can move. So we can see the Supramid suture under the conjunctiva. It can be left like this, and it can be removed by a small incision. That incision can be closed with a single vicryl suture. So this is a patient where I had used a Supramid suture, and even after 6 weeks the intraocular pressure was around 30 with 2 anti-glaucoma medications, and hence I decided to remove the suture. And once I removed the Supramid suture, we can see here a nice diffuse bleb, and the intraocular pressure came down to 12 millimeters of mercury. Even when we insert Supramid suture, it is better to delay the removal around at least for 6 weeks, and then assess the pressure once the ligation gives way, and then decide on removing the Supramid. So in that way, we can take care of hypotony. So this study, the Ahmed versus Barwell study, found that at the end of 5 years, the hypotony related complications were more in Barwell than that of the Ahmed group, and as we all know, it is more common in non-valve devices. So these are some of the pearls. Most of it I have shared then and there only. The one is tube should snugly fit into the scleral tunnel, and consider suturing the entry point. The scleral tunnel entry, whatever we are making, it's always good to suture that so as to avoid the peritubular leaks in the immediate post-operative period. Good to have 2 ligation sutures and venting slits only if needed, and it can be placed closer to that of the ligation so that you have good good amount of the tube available anterior to that of the venting slits to religate whenever it is like needed. Patch graft, even if it is needed, please limit it to the anterior part of the tube, and so that the posterior part can be visualized and can be managed in case of hypotony. And planned ripcord sutures in prone cases is like very helpful. So moving on to the hypertensive phase, any intraocular pressure more than 21 millimeters of mercury during the first 3 months in the absence of tube obstruction is defined as a hypertensive phase. So usually we can see an elevated thick-walled cystic bleb, and before calling a patient as having a hypertensive phase, it is good to rule out certain causes of tube blockage or a valve malfunction or aqueous misdirection. Here we can see a thick debris. This is following AGV in a patient with a traumatic glaucoma obstructing the tube. Here we can see thin fine strands of vitreous blocking the tube, and as we all know, whenever we are implanting a glaucoma drainage device, fibrous capsule forms over the end plate, and aqueous humor usually pools in the potential space between the end plate and the surrounding capsule, and the flow occurs through the process of passive diffusion, that is what gets absorbed by the capillaries. But the thickness of the capsule will determine how the hypertensive phase is going to be, and there is even evidence to say that increased hydrostatic pressure in that potential space between the device and the capsule can make the capsule very stiff because of the aqueous collection over there, and that is more common with valved devices. So it depends upon the resistance to the flow through that of the capsule. As we all know, in valve devices, the flow starts immediately after implantation, and hence in the immediate post-operative period, aqueous is supposed to have a lot of pro-inflammatory factors which can cause thickening of the capsule and higher chances of this hypertensive phase. Whereas in non-valve devices, as we all know, we ligate, and for first 6 weeks it's not going to function till the fibrous capsule forms. By then the inflammation, post-operative inflammation comes down, and hence there is lesser incidence of hypertensive phase with we can obtain a very lower intraocular pressure as compared to that of the valve devices. As we saw, it is more common in valve devices, and various studies have reported various percentage of this hypertensive phase. And there are certain factors which can determine this hypertensive phase, including higher preoperative IOP, presence of myopia, previous glaucoma surgeries, and also the material of the end plate. So evidence has shown these factors. And during the early post-operative period, initially we can use aqueous suppressants to manage the hypertensive phase, and when it is not helping, probably we have to go for other interventions. Using the aqueous suppressants can reduce the intraocular pressure, improve the success rate, and also can reduce the frequency of hypertensive phase. So when this is not helping, surgical management will be bleb needling, bleb wall excision. Sometimes we can even need to do a valve dissection or ligating the tube. And when nothing is helping, as shown by our chief instructor, some patients might need a second tube or a diode cyclophotocoagulation. Thanks to Dr. George sir for providing me this video. This is a child with following an RD implantation, a child in aphakic glaucoma. We can see a thin cystic capsule over there. A careful dissection is, conjunctival dissection is made over the encapsulated bleb, and the conjunctiva is separated from the subconjunctival tissue. So L-shaped conjunctival incision is being made, and so that the post-operative apposition will also be good at the end of the surgery. The careful dissection is made, separating the conjunctiva from the fibrous capsule. We can see how thick walled is this capsule. And as we give the nick, we can see a lot of aqueous is seeping out through the capsule. And this initial incision can be deepened. And we can visualize even the foot plate over there. And the fibrous capsule is over the foot plate is being removed. And at the conclusion, it is since we are removing the capsule, fibrous tissue around the end plate, it is good to put a religation or ligating suture so that it will not result in hypotony, and the conjunctiva is opposed in a usual manner. So this particular study in the Indian population I have basically done to compare RD and AGV. They found that if AGV patients are started on anti-glaucoma medications, especially aqueous suppressants, whenever the intraocular pressure was more than 12, was very helpful in blunting the hypertensive phase. And this particular study reported that preoperative IOP and one previous glaucoma surgery as risk factors for developing hypertensive phase. And this is from our chief instructor, Dr. Josh. And following an RD implantation in the series, they found a hypertensive phase was seen in 32%, which was around 2 to 3 months after the surgery. And the good thing is most of the patients, in almost 94% of the patients, it just resolved with additional anti-glaucoma medications. And the success rate between the group which developed the hypertensive phase and the group which did not develop the hypertensive phase was not statistically different. And in this particular study, like Pakravan et al., they divided the patients following an glaucoma valve implantation into two groups. One group was started on aqueous suppressants, initial aqueous suppressants, and the second group received conventional stepwise treatment whenever the intraocular pressure was high. And they found that at the end of 1 year, there was a significantly higher success rate and reduced hypertensive phase in patients who received initial aqueous suppressants. And hence, aqueous suppressants like beta blockers and carbonic anhydrase inhibitors can be considered in the early postoperative period, especially with AGV. And it reduces the levels of aqueous humor inflammatory mediators and the aqueous with pro-inflammatory factors reaching the space around the episcleral plate will also become less, and hence lesser chances of fibrous tissue on hypertensive phase. Thank you.
Thank you very much, Kavitha. Kavitha has to leave for another session where she has to judge free papers. If there are any questions on managing hypotony or hypertensive phase following glaucoma drainage device implantation, we will ask Kavitha to take it before she leaves.
That's what, like,
does it make sense to make?
So it is always good to be on the safer side. If you are like too much confident with like one ligating sutures, it is not mandatory. But I feel more comfortable that in case if I trim closer to the top of the knot, or in case by chance one is getting like absorbed early or something is happening, the other is always there to take care. But I think with the supramed suture, when we do ripcord for all the cases, probably even one ligation suture will do. So because we have always the ripcord to take care of the hypotony.
Devendra, I'll just add on to what Kavitha said. You cannot be sure that it will dissolve the same day. It can. That is one thing. Second thing is, I would strongly advise everybody to use intraoperative stenting with Supramid. It's called Supralon now. Supramid is a competitive brand. Supralon is available. Orolab has commercialized it. It has to be used for every non-valve device. And you have one ligature suture over the Supramid. You have one ligature suture over the Supramid, one ligature suture just a little anterior to the Supramid, because in a rare instance of the Supramid getting exposed and we are not able to, through the conjunctiva, and we are not able to ligate it. So it's a very rare occurrence, but it's occurred once, and we found that the second ligature which holds the tube anterior to the Supramid has prevented the hypotony, and that dissolves at 6 weeks. And I'm sure Devendra is also using 2 ligature sutures. So,
yeah. So just a comment, for a chronic hypotony following trap or even for this stenting, sometimes there is a iatrogenic cause for hypotony also, like use of carbonic anhydrase or beta blockers. So along with standard treatment of hypotony, you have to stop these drugs. So we have seen some cases with this also. And for tube with Sainiki, I think you can create a large PI to place the tube in the sulcus so that is visible, rather than to place it too anteriorly so that it is visible. That is very long length of the tube. Thank you.
So most of these
how long would you wait to intervene if there is hypotony, AC shallowing, but there is no touch, no iris corneal touch? How long would you wait to intervene, or when would you reform the AC at any point? Pressures are, let's say, 4 to 6 with a non-valve device.
So with the non-valve devices, as I was shown in the slides, usually we just wait for like maybe 2 or 3 days, and usually in the managing hypotony following a non-valve device is like little different from that of the no trabeculectomy, where you can just wait and the fibrous tissue will form, and then it will be taken care of. That slowly the chamber will form. So in my little experience, whatever I have faced is, even when the ligation suture gives way, when you are getting hypotony, in most of the patients, like the chamber, if it is formed with severe inflammation, definitely they will subside. But when the chamber is like so flat, in my experience, I have not seen it getting formed with the conservative management, and 100% of them, in my experience, they landed up in having either intraluminal stenting or religation.
Again, to add on to what Kavitha said, this can be prevented by intraoperative supramid stenting, because you can wait. You can wait till up to 8 weeks before you can pull out, and by then the fibrous capsule is well formed. Initially, we had this fear. Patient comes at 6 weeks post-op. Patient comes, sometimes this Dr. Professor Keith Barton from Moorfields has a good animation where the ligature gives way, the whole globe collapses. That can be prevented by this supramid stenting, and we have many children post-operative 1 year supramid nicely lying underneath the conjunctiva, pressures well maintained. And only problem is this problem with non-valve devices now is a very late unexplained chronic hypotony, where this ab interno supralawn stenting has also become a blessing nowadays. That is the advantage, I think. This is a multi-filament. It's a pseudo monofilament nylon, Devendra. I haven't seen a granuloma being formed. No, but what do you do after that? What did you do after that?
The subconjunctival space where we are leaving the supramid post-operative period, probably.